Thank you, Association of Supportive Care in Cancer Organization, the organizers, Dr. Vikas sir, Dr. Prabhat, for inviting me today for this talk. And like we all know, as far as supportive care in cancer is concerned, fertility is one such topic which is really very important for our cancer patients. So in today's talk, I really have a very short time because it's a very vast topic to cover. So I might be a little fast in the way I talk, but there is a lot of information to be covered in this 10 minutes. And the way the approach to this entire topic will be, which are the cancer patients in need of fertility preservation, what are the factors that you need to see before you offer fertility preservation to our patients, then the overall approach, what are the techniques, and what are the future directions. So without wasting much time, let us begin this topic. So basically, fertility preservation is defined as the use of available technologies to help individuals retain their fertility. The need of fertility preservation is there because the reproductive capacity may be seriously affected by certain things. For us oncologists, the concerning factor is that we give gonadotoxic treatments, and that is why fertility is affected. Besides cancer and gonadotoxic therapies, age related, there are certain genetic syndromes and all which affect fertility. So these come under other conditions. And fertility preservation is a fundamental issue for our patients, those patients who are of the reproductive age group as well as in the prepubertal age group. So all the individuals wishing to preserve their fertility need to be provided counseling about the currently available fertility preservation options, and timely referral to a fertility preservation specialist is very important. So which are those molecules which are really gonadotoxic in our patients? The chemotherapy agents which we use, endoxan, busulfan, melphalan, chlorambucil, the alkylators, ifosfamide, nitrogen mustards. So these are the really agents that can be really gonadotoxic to the patients. So there is a big list of drugs, and we have been classified into high, moderate, and mild risk. And what are the factors that you need to take into consideration before you offer a patient fertility preservation? So in the patient related factors, we should see the age of the patient, any history of addiction, whether the patient has a partner or not, the medical history, ovarian reserve markers that I'm going to discuss about, previous treatment for infertility, any contraindications, any hereditary conditions. And as far as the cancer is concerned, what is the type of cancer, what is the prognosis, how urgent is the treatment required, what is the type of treatment that you have chosen, it is radiation, is it chemotherapy, is it surgery, is it endocrine therapy? So all of these factors need to be considered before you take into account and discuss with the patient fertility preservation. Very, very high risk of fertility getting affected is there if a patient is advised pelvis testis radiation, pre-BMT chemotherapy, patients who are undergoing chemotherapies for Ewing's and all. So all of these are having a very high risk of posing the patient with the risk of infertility, as well as treatments for AML, leukemia, sarcomas, neuroblastomas, Hodgkin's. So all of these pose a very high risk of infertility. And if you notice, all of these malignancies are common in our younger age group. Now, fertility is affected by commonly used treatments such as chemotherapy or radiation or even surgeries. Now that we were all talking about fertility, the two more important aspects that we also need to remember is that even the hormone production is very important. Like, for example, I recently had a patient who was 27-year-old lady. At the age of 27, she already had a family complete with 2 children and all. So she was not much bothered about fertility and everything. But still, at the age of 27, what still matters is her hormone production and also her sexual function. So besides thinking about fertility, hormone production of the gonads as well as the sexual function of the patient also should be taken into account. And more than 80% of the children and adolescents become long-term survivors, raising the interest in the long-term effects of cancer treatment on fertility. Now, in males, spermatogonia are very susceptible to chemotherapy radiation. Sometimes the effect may not be permanent if the stem cells are not fully depleted. And surgical pelvic interventions for malignant or benign diseases may affect the anatomy and normal functioning. Chemotherapy and radiation may induce premature ovarian sufficiency in female patients. Ovarian damage is drug dose dependent, as well as it increases as the age increases because the ovarian reserve reduces as the age of female patient increases. Radiation may also affect the uterus, leading to increased vascularity, myometrial damage. So even if the hormones are not affected, sometimes the uterus can get affected, and fertility may also be impaired by surgical removal or damage to the reproductive organs. Like we just saw, uterus itself can also be affected by our cancer treatments. So now, what is the basic approach to fertility preservation in cancer patient is given in this diagram, and a short discussion about all these treatments will be done eventually. So, what is the patient's? What is the patient? Is it a male or a female patient? Male patient, whether it is pre-pubertal, they go for testicular cryopreservation. If it is post-pubertal, they go for semen cryopreservation. In female patients, is the malignancy present in ovary? Yes. If perform ovarian tissue cryopreservation. If it does not involve the ovary, is the treatment radiation only? If it is only radiation, we can have the ovarian transposition. Can chemotherapy be waited? Can we wait for chemotherapy for 2 to 3 weeks? Yes. If the status is post-pubertal, does the patient have estrogen-dependent malignancy? Ovarian stimulation with letrozole or tamoxifen. Otherwise, ovarian stimulation with conventional agents. And if it is pre-pubertal, again go for cryopreservation. So the same diagram will be explained in a few slides. So it is a multidisciplinary team management. There will be oncologists, gynecologists, reproductive, endocrinologists, urologists, andrologists. So all of these, along with psychologists, will be involved in the care of the patient. So let us see what are the fertility preservation methods in males and females. Before proceeding to those methods, are there any ways in which we can prevent it or spare fertility treatment? So opt for surveillance or less gonadotoxic therapy can be chosen. We can, for example, in a very early stage breast cancer patient, opt for Oncotype DX, try to avoid chemotherapy. Timing for treatment of breast cancer, chemotherapy delayed, we can delay it by so that ovarian stimulation or oocyte retrieval can be done. Tamoxifen delay for pregnancy, photoprotective agents like GnRH, less aggressive resection for ovarian and cervical, like cervical, we can have a fertility sparing surgery, oophoropexy. So these are the things which you can do before giving a method, advising a method in itself can preserve fertility of the patient. What is ART? ART is basically in vitro handling of human oocytes and spermatocytes for the purpose of establishing pregnancy. Currently, IVF with ISI is one of the most successful methods of achieving pregnancy from a bank form. Now, what are the procedures available for female patients is one each that we are going to discuss. So first is the embryo cryopreservation. In embryo cryopreservation, this is possible in those patients who have partners or in whom donor sperms are acceptable. So ovarian hyperstimulation, then there is a oocyte retrieval, then there is embryo branching. One of the most successful form of fertility preservation should be offered to all women who are married. Limitations is that there are high estradiol levels during stimulation may have a negative effect on estrogen sensitive tumors, delays cancer treatment, and not applicable to prepubertal patients. Now, coming to the second method, which is oocyte cryopreservation, with appropriate counseling is recommended for patients facing infertility due to chemotherapy or other gonadotoxic therapies. So, when a woman is unmarried or does not have a partner, a mature oocyte cryopreservation is preferred. Sorry. So this mature oocyte vitrification is preferred in postpubertal women when gonadotoxic treatment can be delayed to allow time for controlled ovarian stimulation. So COS is controlled ovarian stimulation. Whenever the patient wants to go for oocyte cryopreservation, they have to wait a little. They have to undergo this process, retrieve the oocytes. Until then, your chemotherapy might get delayed for 2 weeks, 2 to 3 weeks. Similarly, as mature oocytes, there is also an option of immature oocytes, maybe in the prepubertal girls or in women with aggressive or hormone-sensitive cancers or those who are unable to undergo COS. Now coming to males, there are methods of sperm cryopreservation. It is strongly advisable to complete sperm banking before starting therapy to avoid increased genetic damage in the sperm collected. Collection of 3 to 4 samples with approximately 48-hour periods of abstinence. If the sperm count or motility is impaired or the sample amounts are limited, IVF will be necessary or else IUI is feasible. So if there is a number of sperms are less or the motility is not good, then IVF is necessary. Otherwise, intrauterine insemination is a good option. Ovarian tissue cryopreservation. Now, this is one method which is COS independent. It is going to allow, if it is possible not to delay the chemotherapy, then you can go for this. It is the only option in pediatric and in hormone dependent diseases. Once the ovarian tissue is removed, it can be reimplanted in the pelvic cavity, that is orthotopic, or it can be implanted in other sites like abdominal cavity, forearm, etc., which is heterotopic. Reimplantation of frozen thawed ovarian tissue in pelvic cavity is usually carried out by laparoscopy, and surgical technique is on the presence or not of one or more ovaries. So this is one of the techniques. Earlier it was experimental, now it is very well established. There is also an option of whole ovary preservation. It is basically removal of the ovary along with the vascular pedicle. So it is going to be removed, preserved, and again reimplanted. So this is also one of the newer techniques that has come up. Requires replantation of the whole organ accompanied by the vascular anastomosis. Not a very easy technique, available at few places. Testicular tissue cryopreservation is one method which is still experimental, in which the testicular cells have been harvested, and thus, if the provided samples reveals azoospermia, testicular sperm extraction can also be done. But till date, not a successful pregnancy has been reported by this technique, so it is still in the experimental phase. Oophoropexy, well, like we all know, is just transposition of ovaries out of the radiation field. There can be shielding, which is basically offered. A laparoscopic or robotic approach can be allowed for this, and chemotherapy, if it is contemplated, this can be avoided. And there are photoprotective agents. I think these are agents which are of concern to us medical oncologists. So GnRH analogs protect follicles from destruction during chemotherapy, have been used for a long time. Meta-analysis have found a significantly reduced risk of premature ovarian insufficiency, and protective effect of GnRH is less clear. So it is not a very advocated method of fertility preservation, not a very standard method, but still can be still advocated to the patients. The confirmed data is still pending for this type of method. Now, just summarizing the entire, in male patients wishing to preserve fertility, able to ejaculate, the sperm is there, they go for sperm cryopreservation. They can have assisted ejaculation techniques, and no sperm, they go for testicular sperm extraction. So this is a microscopic technique in which sperms are extracted. And in female patients wishing to preserve fertility, if you have time, go for the ovarian COS, that is controlled ovarian stimulation, using of agents like letrozole to protect against the hormone sensitive tumors, because there is a estradiol levels go very high. So your hormone sensitive malignancies, there is a risk of increasing. So you can use agents like letrozole, and availability is less than 2 weeks. Then they have option of ovarian tissue preservation, as well as this option is there in prepubertal females. So till now we have discussed the methods available with us for preservation. So what are the successful rates? So in this table, we are summarizing the success rates, in which we can see that the embryo cryopreservation is a very successful technique. 22% live birth rates per embryo transfer. Then there is also oocyte, ovarian tissue cryopreservation, as of now still in the developing phase. But all of these techniques have been shown to having good, successful pregnancy outcomes. So results, live birth rate, like I told you, is very, very good with embryo transfer, and it's actually equal to the fresh embryos in non-cancer patients. Oocyte vitrification are also good results, but ovarian tissue grafting, we have had a few good results. So one of the result is in a 13-year-old girl who underwent a transplant and had her ovary cryopreserved. And semen preservation with greatly advanced techniques of ICSI, the pregnancy rates up to 57%. And even in some studies reported a successful rate of 62%. So it is a very, very good success rates with semen cryopreservation. Now, in reproductive age women facing gonadotoxic treatments, of course, it is important to remember that early access, early referral to appropriate reproductive endocrinologist, infertility specialist is essential, multidisciplinary approach. But what I want to stress over here that this article also showed is that serum FSH, AMH, AFC count should be done prior to chemotherapy. So there can be patients who might already be infertile prior to you starting any treatment for CA breast. So you have to document that before and show them that this were the levels prior to starting the gonadotoxic therapy. So this reserve, assessment of ovarian reserve, is also very important. Now, recommendations of fertility preservation options, like we have already seen, I'll summarize it with the ASCO guidelines in the end. ASCO guidelines for fertility preservation, this were published in 2018. I tried to search for the latest, I was not able to get it, but 2018 guidelines, which I was able to find. Coming to the conclusion of my talk, these are the last few slides. Healthcare providers caring for an adult and pediatric patient should address the possibility of infertility as early as possible. They should refer patients who express an interest in fertility preservation to reproductive specialists. To preserve full range of options, fertility preservation approaches should be discussed as early as possible before the treatment starts. Documentation of everything, your discussion with the patient, their reports, their semen analysis, ovarian reserve reports, everything is really important. Now coming to the summary of what are the options for adult men, we have sperm cryopreservation, very effective, very successful. Hormonal gonadoprotection, like we used in females, is not an option for men. And testicular tissue preservation and all is still in the experimental stage. For women, embryo cryopreservation, again a very successful technique. Cryopreservation of unfertilized oocytes also is a very good option, especially for unmarried females. Fertility preservation, more flexible ovarian stimulation protocols are now available. Harvesting for the purpose of oocyte or embryo is now possible on a cycle day independent schedule. Special concern, estrogen sensitive gynecological malignancies, of course we are concerned in them. In them, use of letrozole and tamoxifen is allowed, and AI based stimulation protocols are now well established because of this concern. Fertility preservation options for adult women: ovarian transposition, we know in case of pelvic irradiation; conservative gynecological surgeries like like in patients of CA cervix, and young benign patients who have ovarian tumors are young females. So there are certain surgeries which are fertility sparing, which can also give them this option. Then ovarian suppression, in which we use GnRH analogs, as of now not a proven fertility preservation method, but should not be used as only a sole method, can still be used as an ovarian protective agent, but cannot be advised as a sole method to preserve fertility. And then there is ovarian tissue cryopreservation transplantation, which is now no more in experimental stage, now being used very widely. Role of healthcare providers, or I would say oncologists, in this is to discuss these options, refer appropriately, encourage patient to participate in these techniques, refer patients to express an interest, as well as those who are ambivalent to specialists. Always remember, in case of children, to take the consent of parents. The parents are the one who have to take a decision and decide which method they are going to opt for or not going to opt for. And also the role of psychologists in this is also very important. And the last, maybe in children, we have methods like semen and oocyte cryopreservation for post-pubertal, but in pre-pubertal there are only options like ovarian and testicular cryopreservation, which are still, in the experimental stage. So we are trying to develop this method. So that is concerning the prepubertal boys and girls. So preservation of gonadal tissue, spermatogonal cryopreservation, ovarian tissue cryopreservation. Okay, for Hodgkin's and all, we can still have this option of ovarian transposition and fertility preserving surgeries, etc. But still, for prepubertal, we still are lacking. We need to have more approaches for this age group. So as of now in India, in Pune, Mumbai, we have these facilities of embryo oocyte preservation, sperm banking, cryopreservation. All these techniques are now available. One point which I want to emphasize is that they are not very cheap. We should make resources available for our patients, who present to us in setups in government hospitals or in setups like maybe Tata Hospital. We need to give them patients which are more economical, options which are more economical. And there are now many experimental procedures like existing germ cells, bone marrow transplantation, oocyte and zygocyte micromanipulations. There are many ethical issues also involved, like sometimes some patients may opt for donor gametes, donor sperms, donor oocytes, surrogacy. So a lot of medical, legal, ethical issues, but it's beyond the 10-minute talk which I have been given. So these issues are also there, psychosocial issues are there. All of these factors together as a multidisciplinary team need to be addressed. We also have the ISMO guidelines for fertility preservation and post-treatment pregnancy outcomes. We can all refer to this article also. They have also given us guidelines. And coming to the conclusion, as the number of cancer survivors is increasing, the need of fertility preservation is increasing. It should be a priority when treating children or adults of reproductive age group that may, with agents that may have hazardous effects on reproductive system, and gonadotoxicity as much possible should be kept at the minimum. So there is increasing need of advocacy awareness. Now, even if we were to counsel many patients, it is only 30% who actually opt for this decision. So this percentage of patients who understand this and actually go for this method should increase. We need to make these fertility preservation methods really economical for our Indian population. Fertility treatments and pregnancy. Plus, there are some myths like do they affect the pregnancy outcomes? Will the child be born with certain birth defects? Then prior treatment with chemotherapy, radiation has not been shown to cause birth defects in the offspring. Multiple options to ease the cost associated with fertility. So these are also the myths that we need to reduce. And if you give options of fertility preservation and your patient is able to get cured of cancer, as well as if they are able to have a child successfully, I'm sure they're going to really thank you. So thank you so much, organizers, for giving me this opportunity today. And thank you so much, and good evening to everyone.